Dear Chairman, dear colleagues, thank you very much. I would like to thank the organizing committee for their kind invitation. So we will talk about a TAVR patient, bicuspid and large annulus. So we will begin with the patient. It's a 77-year-old male with hypertension, dyslipidemia, AEF, carotid stenosis. He was autonomous in his everyday activities. So he had an LV fraction of 50%. In the last 3 months, he had developed NIHA 3, an AVA of 0.9, and this is the risk source of our patient. So when we performed the CT, we saw that it was actually a bicuspid valve, and it was actually a very large annulus. So you can see the area is 773. So we had the problem of choosing the valve for this patient. So if we go and see how the valves and their specifications, we can see that the Evolut platform was not correct for our patient. Either the Accurate platform and the Edwards platform was not, could not fit our patient and the APA device. So we had to use the MyValve system for our patient. So this is the setup that we use for our procedure. So we use opioid-free anesthesia for sedation. We use a temporary pacemaker from the left femoral vein. We have the pigtail, and we use the left radial artery for this. The closure device system we used for this patient was the Manta device, the 14th-French Python sheath. Valvuloplasty would perform with a 26-millimeter balloon, and we would use the MyValve system, the 32. So what we should know when we are discussing about bicuspid patients is this is the common classification that we use. So for the type 2, I don't think that there is any available data for this patient. It's very rare. So we usually go for the type 0 or for the type 1. There is also another classification that is specially used for the TAVI procedures. But we should always keep in mind doing bicuspid is that this is the anatomy that we have. We have here, sorry. Okay, as you can see here, I will use, can you see? Yes, okay, so if this is our annulus, this is something that we must always take into account, that if we have a RAF, it's actually above our annulus plane. So what we should know is how to exactly measure in the CT, and how do we choose a valve? Because if you're going to open a valve, and if it's a high frame, this here will probably restrain the full expansion of our system. So using the CT, we can see how this can affect the expansion of our valve. So there are 3 methods available that you can use. The one is the Bathard method from Cheche, which actually use 4 millimeters above the aortic annulus in the intercommissural distance. But there are some colleagues from Italy that are now using the Lyra. It's implantation at the level of the RAF. So you can see here in the CT that someone would measure this. So this is our annulus plane. This is the 4 millimeters above, but the RAF is actually 10 millimeters above our annular plane. So when you're actually thinking of implanting a valve, you should know all this, because this will probably predict how your valve is going to expand. Because concerning bicuspid, there isn't a single bicuspid that is common. All bicuspids are different, and the anatomy is different in every valve and in every patient. So in the literature, there's always this algorithm, the Caspal algorithm, that actually uses the calcium score in the CT. I don't have any experience using these systems. Now we're actually in our hospital, we're using the first one and the second one. But if someone has experience using this system, I will be very glad to know. So going on with our case, this is the orthography in the initial one. As you can see, there's some calcification, and there's a very bulk of calcium towards the left coronary sinus. So we performed the valvuloplasty, and what I would like to show you this and keep in mind is because we have the RAF, and the RAF is above the annular plane, you might see what we have as a dog bone effect. It's probably some millimeters above your annular plane, because this is where the RAF is, and this is what you should anticipate when you're doing valvuloplasty in a bicuspid valve. So after this, We did an arthrography just to be sure about what was going on. We did not have any hemodynamic instability. And then we started to implant the valve. So as you can see here, when you're going with a bicuspid valve, we have a tendency to not put it as deep, so we went about 1 millimeters above our initial, what we normally do in a tricuspid valve. And you can see here that the valve, because it's a very large annulus, it's a 32 millimeter valve, we had really to start, when we started to inflate, it was very difficult because, as you can see, it's a little bit slight more high, the pressure of the valve. And we were really inflating. At the end, we saw that this liter here, this thing, we wanted to be, because this would affect the expansion of our valve and probably our long-term outcomes. So we inflated the valve, we were pushing. At the end, this is the result with the guide wire in the left ventricle. There is minimal paravalvular leak, and this is our final arthrography. It's a very good result. The valve is a little bit more higher than usual, but this is what we were thinking, and this was our plan from the beginning. So take-home message, you have to have a clear setup of the procedure, especially when you have two possible pitfalls, bicuspid and large annulus. In young patients, coronary protection is important, and you can almost keep in mind that you may need to recannulate the coronary, so choose wisely what valve you're implanting, and proper valve selection is of paramount importance. Thank you very much.
Very well done. Any questions from the panel? Any questions from the floor? Yes, sir. Dr. Halapas?
Great, Antonios. Great presentation. Just as far as the sizing is concerned, you have the three methodologies that you have already described. However, there is two more. The one is the circular sizing methodology, especially when you use the balloon expandable valves. And the last is the balloon sizing when you are in the gray zone, just as an additional comment.
Just follow up on Andoni's comment. What was the size of the balloon you used for the valve?
It was a 26 millimeter balloon.
Okay. So the balloon sizing with the 26 millimeter balloon, so no peri-balloon leakage, which means that even 29 valve would be
fit,
fine.
Yes.
And I think that was the reason you couldn't really expand the 32. You had the waste. So this is, as a general rule, if you have bicuspid valve, and the more calcium the bicuspid valve has, so you can downsize the valve you're going to use. And this is true for both self-expandable and balloon expandable. So if you have bicuspid and you are borderline between two sizes, go with a smaller size. And this holds true, especially if you have a lot of calcifications, like you had. So the more calcification you have in a bicuspid valve, the more you can downsize. And then the other thing is that where the calcification is, if you have a calcified trough, these were the highest risk bicuspids, and you had a calcified trough. So these are the highest risk because this is like a pillar of calcium that holds you away from the annulus. If you don't have a calcified trough and you have calcium elsewhere, then this is an easy bicuspid. So I think in general, these are the bicuspids that we should still discuss with the surgeons, especially in younger patients, and given the results of the Notion 2 trial that we've seen so far. Excellent case. Thank you.
There's one last comment from Professor Kilic in the back.
Congratulations for the excellent case. Another point for Professor Spargias, that we can also measure the supraannular measurements in bicuspid aortic valve, like from the Bavard registry. And there are also two other methods that where the bicuspid raphe is this. shape of the valve, according to these measurements, can be tubular, flared, or tapered. If it is, for example, tubular, you can use the same size of the valve. For example, if it is equals to 32 tubular, you can use the 32 millimeter. But if the supraannular measurement is lower than the original annulus, we should go to smaller size. The problem with the other balloon expandable platform is the absence of the intermediate sizes. In my wall and the new core series, there are intermediate sizes. So, for example, if you use smaller valve in a very calcific area, for example, you should put extra amount of contrast, and this means risk of annular rupture. Or if you use larger size in a very non-calcified area, for example, this means the risk of the development of paravalvular leak. So the intermediate size really make great game-changing in this balloon extendable area. Thank you.
Okay, thank you. One last comment for the comment of the comment.
If you use the balloon sizing with simultaneous orthography for bicuspid valves, you shouldn't be stingy and misery with the amount of volume you give. Because if your pigtail is on one side of the aorta and you give just a little, like the usual 20 or 15 mLs, then you may not appreciate the regurgitation you have at the commissures. So the commissures are tiny, your contrast is in one direction, so you don't appreciate it, and you may be misled, and you go then with a smaller valve like a 26 here, and then you get a lot of regurgitation, PVL, and you won't be able to fix it. So if you use the balloon simultaneous orthography, use a lot of contrast, at least 20, 20, 20.
Okay, so we all agree that the only outlier in the TAVI cases probably are the bicuspids. We have to carefully review the CTs and be ready to change our plans in flight. I would like to thank everybody for staying with us so late in the afternoon. I would like to apologize to the organizing committee for taking half an hour from our lunch break. Hope you will forgive us on that. And